Welcome everyone to Wednesday Night at the Lab. I'm Tom Zinnan. I work here at the UW-Madison Biotechnology Center. I also work for UW Extension Cooperative Extension, and on behalf of those folks and our other co-organizers, Wisconsin Public Television, the Wisconsin Alumni Association, and the UW-Madison Science Alliance, thanks again for coming to Wednesday Night at the Lab. We do this every Wednesday night, 50 times a year. Tonight, it's my pleasure to introduce to you Pete Schultz and Tom Haupt from the Wisconsin State Laboratory of Hygiene. Tom was born in Manitowoc, Wisconsin, and graduated from Manitowoc Lincoln High School. Then he went to UW Parkside, which is celebrating its 50th anniversary this year. There in the wonderful Petrifying Springs Park where we used to go to for our family reunions back in the late 60s. At UW Parkside, Tom studied public environmental health and then got his master's degree in healthcare administration from Cardinal Stritch College. He started with the state in 1985 and then has been with the Department of Health since about 1995. Pete Schultz was born in East Lansing, Michigan, and grew up in Oconomowoc, Wisconsin. I could tell that I was long enough in Wisconsin that I could pronounce Oconomowoc. He went to UW-Madison for all three of his degrees. All three of them were in Med Micro at the undergraduate, master's, and PhD level. And then he spent 2 years as a postdoc in Christchurch, New Zealand. And he came back, which is pretty amazing. And he's been with the Wisconsin State Laboratory of Hygiene since 1988. Tonight, he's going to talk with us about they're both going to talk with us about influenza. It's not just about pandemics. I hope you've all got your flu shots. It's a pretty amazing thing. 88,000 people died from flu last year. Let's see if we can drop that number a little bit this year. Pete's going to go first, so please join me in welcoming both Tom Haupt and Pete Schultz to Wednesday Night at the Lab.
Thank you all, and thanks to Tom and the Wednesday Night at the Lab crew. It's my second time here. I really enjoy doing this. So I'm going to talk about influenza, and the title, not exactly along the lines of pandemic, but that'll become obvious why we're kind of taking this tack as we go through the talk. Want to begin with this slide. The reason we're having this trilogy of presentations on flu is I think everybody now realizes this is a centennial of the great influenza pandemic of 1918-1919, which really in human history ranks as one of the biggest and arguably most impactful global health crises in human history. CDC is also recognizing the centennial, and they put together just a tremendous website. If you want more information on the science, on the historical aspects, the societal impacts, this is a great website to go to. I'd recommend everybody do that if you have interest in the topic. And just to get started, we're going to stray from pandemic influenza in fairly short order, but just want to highlight some of the facts. And again, I think a lot of people know about this. There were a lot of somewhat unique attributes to this pandemic, very notable things. This slide illustrates that actually the pandemic event occurred as 3 distinct waves over about a 1-year period, with the second and the third wave being the most devastating of the two. When all was said and done, estimates of 50 to 100 million people died worldwide, over 650,000 in the U.S. A couple other really amazing facts. The case fatality rate was in excess of 2.5%, which in the worst pandemic since then and the worst season since then were around 0.1%. So really remarkable there. And during this period, during the three waves, it was estimated that a third of the entire global population, well over 500 million people, suffered clinical illness of varying degrees. So, and then there's been a lot of comparisons over time, comparing to the impact of the pandemic in World War I. And one other kind of interesting thing on this lower curve, for a couple-year period, this pandemic actually lowered the average life expectancy by 12 years, which is, when you think of it, really quite remarkable. That's in the United States. Some elements of the disease were also very notable. Most of the cases were like typical, albeit on the severe end, influenza, but what's really highlighted are the 15 or 20% of cases that developed the pneumonia. And it was a very characteristic pneumonia, should be quotes around that italicized part, unlike anything that had been seen. And basically, it was mentioned last week, there was an excellent presentation by the three scientists from UW, gave a little of the scientific background on this. And it was pointed out that the direct cause of many of those cases of pneumonia was in fact bacterial, and there's very good evidence to support that. But in fact, it was very much a 1-2 punch. The virus hit first and actually did considerable damage throughout the respiratory tree and just sort of opened the doorway to the bacteria that normally inhabit our upper respiratory tract to go down there, get established. And it was primarily the bacteria then that was the result of the end stage for a number of these patients. And then the second really remarkable thing, we'll mention it probably later, but it's pretty characteristic that influenza has its most severe impacts now at the age extremes, the very young, and particularly those greater than 65 years of age. And that's highlighted by that dotted, dashed line. And this just shows seasons before and after 1918, and it's a pattern we've seen consistently ever since. What made 1918, 1919 a bit remarkable was the W-shaped curve, that a substantial part of the mortality and very severe illness occurred in otherwise healthy adolescents, young adults into middle age, which made this even more devastating, the impact this would have in communities, since this is the most active, vital part of the community. And this is something that is not been seen certainly to this extent with any other pandemic. So originally, I think Tom alluded to this last week, the original topic was really going to discuss the impacts of the Great Pandemic, both back then and what are some of the lessons that we have learned that are applicable to today. And in thinking about this, I decided that might not be the best use of this hour. I showed these different books and magazines, and I already referenced the CDC website. You can find, if you go to these, excellent scientific descriptions of the disease, the public health impact, the societal impact of this pandemic. And I'd encourage you, if you're really interested in this, to pursue some of these. These are really tough books to put down. You're just in awe of the impact that this pandemic had. Rather, what we decided to do is fast forward to what happened last year. Of course, in public health, we worry about pandemics, but something we're going to tell you through the course of today, we deal with influenza epidemics on a year-to-year basis. And last year was really an eye-opener. So why did we do that? Why did we choose to focus on that? Well, I show up just kind of a little collage of some headlines from last year. There's been a tremendous amount of press devoted to last influenza season, the most recent of which, and it kind of culminated last week when the CDC came out with a report documenting that last year over 80,000 people died, 900,000 hospitalizations, and a particularly severe impact on young children, which in their estimation makes this easily the most severe epidemic we've had in over 40 years. In addition, as you followed the news throughout the year, we heard of school closures, ERs and urgent care throughout the country being overrun. Hospitals had to divert patients because they couldn't take anymore. There were shortages of medical supplies, saline, some antibiotics, antivirals, laboratory supplies in certain areas, particularly associated with influenza diagnosis. And what made this even more remarkable, it's not something we knew was going to happen, even as we hit the typical part of the influenza season when we know it's going to be taking off. There were no indications from flu the summer before, where flu is active in the southern hemisphere, that there was going to be this severe year. And even a couple weeks into the season, there was nothing that made this seem and there was going to be anything unusual. And the virology, the information we had about the viruses we'd expect, there was nothing remarkable. The season hit, and it truly became a historic event. So what I'm going to do is talk to you a little about influenza and make the distinction virologically, the differences between pandemic influenza and seasonal influenza. There's distinct mechanisms that allow the viruses that cause either pandemic or seasonal influenza to arise. And I just want to review that, keep it not too scientifically detailed. I'll turn it over to Tom, and he's going to focus on last year and past flu seasons, talk a little about the clinical, the public health impact, and perhaps the most important part of his message moving forward is review what you can do to help yourself as we're coming into the next influenza season. So we'll be talking about the antivirals available and the vaccine. And then it's going to come back to me. Given the severity of influenza, we can take some solace, even though we don't know what's going to happen on a year-to-year basis until we're in the middle of it. We have an incredible surveillance system, global surveillance system. And I just want to review the highlights and where on a year, throughout the course of a year, you can access those information and kind of be more informed on how the influenza season is progressing. So, quick virology lesson here, and I put this up kind of, you see cartoons about influenza a lot. We saw one last week. But I just want to highlight a couple of the features. And this is done in the context that the real hallmark of influenza is its changeability, its ability to mutate. And there's a couple major ways it does this. I'm going to go over each of those. One of the mechanisms leads to pandemic influenza. The other, much more subtle mechanism leads to the seasonal epidemics that we experience each year. And I just want to lay that groundwork so you understand the difference between the two. And be sure, as bad as last season was, it definitely was not a pandemic, both on virological grounds and also in how the rest of the globe was involved. So the things to know, we'll be talking throughout the talk about influenza A and B. There's two types of influenza of public health significance. Of the two, influenza A is the only one of the types capable of causing pandemics and in general causes more severe disease and bigger epidemics. That said, as Tom can attest, we see in the laboratory, influenza B in its own right in certain years can contribute to significant morbidity and mortality. So I don't want to minimize it, but in the context of today's talk, it's really about influenza A. Couple features of the virus that are very instrumental in how this virus changes those two different ways. One of these is its genome, its genetic material that allows itself to replicate itself is RNA-based, and any microorganism that is RNA-based has that really nasty habit of mutating all the time. Influenza is the greatest example of it. HIV is another excellent example of it. It's also segmented. So the genome has discrete segments. Each segment serves as a gene. And I'll talk about the consequences of that in a second. And then the other feature that is relevant to both types of mutation, the two features, the proteins that are on the surface, the hemagglutinin, abbreviated as H, the neuraminidase, abbreviated as N. That's how we determine the subtype of influenza A. H3N2 is one of the subtypes of hemagglutinin and neuraminidase. H1N1, which is the other subtype currently circulating these days, another similar example of that. These two proteins are instrumental in this virus creating the infection in your body that leads to the illness. It allows it to attach to the cells, infect the cells, move on to new cells, cause illness, and ultimately leave the body and go on to infect other individuals. Of equal importance, it's against these proteins that our immune response is directed. Okay? The unfortunate thing is there are also two of the most changeable proteins, or the genes that govern those proteins are the two of the most changeable genes in the virus. You can surmise this is a bad combination. The two key proteins that are most changeable are the ones we happen to mount our immune response to, which means, in short, our immune response on a population basis is always playing from behind. We're always a step behind. And that's what makes influenza such a very successful pathogen. So, the two ways in which it changes antigenically. One of these is called antigenic shift. And I've defined it when there's a novel subtype, a new subtype humans have not seen of hemagglutinin and neuraminidase. And this can only antigenic shift only occurs with influenza A. When this virus emerges in a human population, it's one of the necessary precursors for a pandemic. And the mechanism it does this, and I'll only briefly mention this because it was talked about last week. Mechanistically, this occurs because of that segmented genome. And if you get two unrelated influenza A viruses infecting the same host at the same time, they start selecting and picking and choosing those genetic components. And if a new virus that we show down here comes up and ends up with a new set of hemagglutinin and neuraminidase that are novel to humans, then we're being set up and there's a potential for pandemic influenza. And the process by which this occurs is called reassortment. How this and where this occurs in nature, again, was talked about last week. Influenza, actually, the primary host of influenza are migratory waterfowl throughout the world. They carry the entire genetic repertoire of influenza A viruses. 16 HA types, or 16 hemagglutinin types, 9 neuraminidase. There's a couple others that have been found in bats. We don't know what role they play in human illness at this point. But these migratory waterfowl are reassorting these viruses all the time. And occasionally these get into other hosts, a variety of mammalian hosts, other birds, domestic poultry. The problem arises when they get in and establish in those animals, such as swine and poultry. That puts them in closer contact to humans, who in many other areas, because of their agricultural practices, humans live in close proximity to swine and poultry. So this gives a real opportunity for these novel subtypes to get into humans, which again raises the possibility of a pandemic. This model has been shown to now retrospectively looking back at all the pandemics we've suffered since and including 1918. 1918, it's well acknowledged that it was probably set off by an avian virus, but that virus was created because of reassortment going on in other avian species. That led to the H1N1 pandemic, and that virus was with us for many decades until it combined with another avian virus, and the new virus picked up different components from that new avian virus, and we ended up with the H2N2 virus, the cause of the Asian flu in 1957. Similar event occurred in 1968 when the H2N2 reassorted with another avian virus, and we ended up with the H3N2. And progeny of that H3N2 are the ones that are affecting us today by the other change mechanism that I'll talk about. And finally, in 2009, H1N1 2009 arose. If you were at last week's talk, a really good explanation, extraordinarily complex series of reassortments involving pigs in different parts of the world, multiple avian species, and humans. And when it all was said and done, the dust settled, we ended up with the pandemic strain that caused the 2009 pandemic. And the consequences of this is pandemic flu. In the interest of time, I'll lead you read about this. Basically, pandemic flu is a global epidemic that has these characteristics. Very rapid spread, occurs pretty much around the world at the same time, often with more severe disease. And because of all that, there's a lot of other significant social impacts, impacts on infrastructure, and so on. Now, these novel influenza viruses are generating all the time, and we've seen in the last 5 to 10 years a strong uptick in the number of these novel viruses that are being identified. And when I talk a little about the surveillance, I'll show how this is being picked up globally. But we're seeing a number of these, and a number of these have infected humans, and to a certain extent, in a very serious way. We heard about the H5N1 virus, the H7N9, which have been with us in the former case for almost 20 years now, and the H7N9 over in China the last 5 years. Capable of causing human disease with mortality rates in excess of 50%. But what hasn't occurred with those leads to this final slide about pandemic flu. There's a recipe for a pandemic. You need the emergence of a novel subtype. You need infection and illness to occur in humans, but you need efficient and sustained human-to-human transmission. That has occurred with our past pandemics. This has not occurred with those other novel subtypes yet, but the number of mutations to make that leap are not large. So it's something we have to be concerned of. So with that, I want to briefly tell you the second mechanism of antigenic change is called antigenic drift. Much more subtle, always occurring as influenza circulates around the globe. And the impact of antigenic drift is seasonal influenza. What happens, the hemagglutinin and neuraminidase acquires mutations that keep it a step ahead of our immune response. It causes an epidemic everywhere in the world, every year, different times depending where you live in the world, and is the reason we have to essentially re-engineer our vaccine each and every year to try to keep up with the virus. The consequences of that is our annual flu epidemic. I show that at the bottom. These are data from the state lab, and the considerable public health impact that influenza has each and every year. And I'll leave you to read the number of cases that occur every year in a typical year, number of hospitalizations, and number of deaths. And you can see how this impacts us globally as well. You can see why last year, compared to what the mean has been essentially for the last 20 years, why last year is considered a historic year. So with that, I'm going to turn this over to Tom, and he's going to pick up with what happened to us last year and what's been the impact and what can you do about it.
Thanks, Pete. Appreciate it. And welcome to Wednesday at the Lab. This is my first time here. Very proud to be here.
I do want to add a couple things to my bio very quickly to what Tom said earlier. Back in 1997, the CDC actually made the first designation of having state influenza surveillance coordinators. Our jobs were to kind of pull together laboratory, outpatient, mortality, hospitalizations all together, so we're all saying the same thing. And I'm proud to say that I'm one of the 2 remaining original influenza surveillors in the country. So thank you very much. I will also share that with my colleague from Connecticut on that. So influenza activity in the United States, we were actually in the Department of Health Services very blessed to have a great relationship with the State Laboratory of Hygiene. Not a lot of other states have what we have. Some of the Department of Health do not even know who their laboratorian or laboratory people are. It really is kind of scary how some of these things happen, but we've developed a relationship over my 24 years here to really talk to each other, get on the same page. Hey, we have disagreements, we all do. But again, it's something that we have been very blessed with in Wisconsin to have one of the best relationships between Department of Health and the State Laboratory of Hygiene. One of the main ways I wanted to show you some information, both federal, United States-wise, and also I'm going to Wisconsinize it a little bit. But this first slide, the top portion is the severity, and you see this on like the Weather Channel and some of those other stations will show this. Obviously, the more red, and closer to the red, the more severe, the more intense influenza is. And this is influenza-like illness, which is defined as a fever and a cough or sore throat. Fever with cough or sore throat, nothing more than that. But this top picture shows that all but 6 states were in the red high range back in the 3rd week of February, around February 3rd, actually, the 1st week of February. This has never happened before. It's never been more than like 15 to 20 states. We had 44 of our states actually in the red at the same time. The bottom one is geographic spread, and never have we had all 48 states plus the Alaska, or 49 out of our 50 states, to actually be at widespread activity. And the widespread activity is something that I'm responsible for. I am looking at outbreaks, I'm looking at influenza activity through laboratory surveillance, putting this all together through a formula they have. We report on a weekly basis down to CDC. But these 2 maps show you things that have never happened since we started this surveillance back in 1997. Influenza activity in Wisconsin over the past few years. You notice the highest is actually in the 2014-15 season. If you recall, the 2014-15 season was the year that the vaccine and the viruses did not match at all. But this past year, which is shown in the red right here, while it was lower, it was a much, much longer year. And the past 2 years have been, and this is actually the influence of the influenza B viruses. The influenza B viruses really extended our seasons the last 2 years significantly. It also hit the elderly population. I'm going to say the older population. I know sometimes I say elderly, people don't like that. Slightly older population. Somebody told me at work to say seasoned. I don't know if that cuts it or not. I don't know. You tell me if you like that word or not. But again, it hits the slightly older population harder than it does the younger population. And that was very significant this year because many of the people over 65 years old had the Fluzone high dose or the adjuvant vaccine, and that did not cover the influenza B virus that was circulating. So they were hit very hard towards the end, making it a much more extended season over the past few years. Flu mortality. These 2 graphs are from what we call FluView, which CDC puts out every week. And you can see how high our mortality was. This is nationwide, by the way. This is United States. We had some of the highest numbers, highest percentages over the past 5-6 years. Also, our number of deaths, the number of pediatric deaths. We all heard that there was 80,000 deaths estimated this past year. We had 180 children, 80% of which were not vaccinated, or the family members. That is the highest we've ever had. Well, it was very close to what we had in the pandemic. The pandemic, I think we had maybe 200. But in a non-pandemic year, this is, again, a record we're not proud of breaking. Influenza and pneumonia in Wisconsin, thought you might be interested in that. And again, it shows very, very clearly the number of flu cases in Wisconsin this past year where they actually diagnosed and it was caused by influenza was 379. The next highest was in 2014 at 267. You can clearly see that the H3 years are much more powerful and much more deadly to people who are not vaccinated, and even to those people who are vaccinated who have underlying illnesses. Vaccine you depend on, but you also depend on those people around you to get vaccinated to make sure that they get the proper protection. But this is also influenza and pneumonia, and this is something we're going to be tracking very closely this year. In our weekly report, perhaps some of you have seen it, we're going to be putting the numbers in. We're going to have them by age group. This is an eye catcher. We want people to know how deadly influenza is, and this is going to be part of our weekly report. We also hope that the media gets a hold of this because we want to have every opportunity to get our message out to the media much faster, much more accurate than what happened last year. If you happen to remember last year, they had this early season total of the vaccine efficacy being about 10%. And even public health people who shied away from the vaccine at first. It was really very, very poorly done. We want to get ahead of the game with the media. We want them to call us. We want to explain the situation. We want to encourage vaccine until there's no more vaccine available or it has expired. But again, you notice the difference between like the 2014-15 season, which is right here, very thin, very small as far as going up and down very quickly, much wider, much longer season in 2016-2017. Flu hospitalizations, this is a graph of influenza incidence by age group. You can see how very, very large the incidence is overall compared to other ones. And this is not only overall influenza, it's also the over 65 range, over 65 people adult by age group. So again, it was a year that hit the over 65 population much, much harder than anybody else. We had multiple nursing home and long-term care outbreaks. We had probably close to 500, and that's over the season. And you think it's not hard to follow up on them? I mean, did I do my job? I did the best I could. But, you know, I depend on the local health departments to help them out, to make sure they know the guidelines, the precautions to take, know when to use antivirals, what antivirals to use. But again, it was this very, very overwhelming year for all of us at the Department of Health Services and the State Laboratory of Hygiene. This is flu hospitalizations in the last 5 years in Wisconsin, and I have last year's in red. We had 7,530 hospitalizations. The next highest we had was 2014-15, where we had 4,700. So we practically doubled what I thought was going to be one of the worst years, 2014-15, that we had in decades. Turns out this year really overshadowed that and made 2014-15 look pretty mild. But again, 66% of all of the hospitalizations are people over 65 years old. Hospitals were overwhelmed. They did diverting, as Pete had mentioned earlier. We didn't have to, there was nothing like making, in California and Atlanta and some of those places, they actually had to build tents in order to get patients their treatment. It didn't get quite that far, but there were a lot of hospitals that had absolutely no place to put people. It was a situation you would probably see in a pandemic, but again, it wasn't as bad in 2009 when we actually did have the pandemic. But this year overpassed the 2009 in just about every single category. And you look at influenza hospitalizations, you always want to look too at the adverse effects. Now, we're looking at ICU admissions, people who are put on mechanical ventilation. Almost 1,000 people wound up in ICU last year. And of that, like 273 people were required to get mechanical ventilation. Very serious year. Much higher numbers in every category, broke every record, and not a record we wanted to break. So why was the past season so severe? When you think about it, it was the same vaccine and the same virus that was going through on the 2016-17 season. I didn't think it was going to be as bad. I thought we'd have a lot of immunity because we had the same vaccine and there was the same viruses. The viruses pretty well matched too. But there was vaccine efficacy issues. And I went so far as to do a media interview and say, I don't think it's going to be quite so bad this year. I hope that has been erased. I hope it's no longer on YouTube or any place like that. If it is, I apologize because I really put my foot in my mouth at that particular time and I have learned my lesson. So why was it so bad? One of the things I wanted to show you, and they put together a model at CDC, and it's based on outpatient influenza-like illness, hospitalization rates, and pneumonia and influenza mortality. And this past year was the first time since they went back to 2004 that all the age categories were in the high category, as demonstrated by the circle on this chart. Other years, like 2014-15, it really hit the elderly population very hard, but not so much the younger people. It was a bad year, but it wasn't a year where CDC actually went so far as to say it's very severe. It's always been moderately severe or mild to moderate. That's been their terminology for years, but this again is a record we didn't want to set. But this is a new model they have. We're going to be watching this very closely. This is done at CDC, but again, they work with us through influenza coordinators and through the state laboratories, public health laboratories, to share this information. We do a lot of talking. We do a lot of talking and a lot of listening on both parts. So that's probably the best thing that we have done, is to just listen to each other and talk to each other, make sure we're all on the same page. Influenza prevention and treatment. Again, we're looking at vaccination, antivirals as two of the main ways of preventing and treating influenza. And we can get into some details. Seasonal influenza, antivirals. Years ago, I don't think it's been like before 2009, they actually used adamantanes, which is amantadine and romantadine. Those were never effective against anything except influenza A, so there was no effect on influenza B. Also, the specimens, or the viruses that are circulating today, the PDM H1N1 and H3, are susceptible to neuraminidase inhibitors, but there's a resistance to the antivirals, to the antiviral adamantanes. Adamantanes also have a very adverse effect on the older population, especially in nursing homes. There's increased falling because of the amantadine and romantadine. Neuraminidase inhibitors, as Pete was mentioning earlier, Tamiflu or its generic equivalent is probably the main antiviral that people use. It's done orally. It can actually be put into a solution for small children. People do not use zanamivir very often. It's also called Relenza. It's an inhalant, and people who have respiratory disease do not want to use it in some kind of inhalant of powder. Peramivir is IV, and that's for people who are hospitalized who cannot take oral antiviral. For people who maybe are maybe are in a coma or something because of their illness. Very much used only pretty much as a last resort, not used for prophylaxis, where Tamiflu or also Tamivir and zanamivir can be used for both treatment and for prophylaxis. Again, as I mentioned earlier, PDM H1N1 and H3N2 are very susceptible to neuraminidase inhibitors. And one thing I wanted to mention too, there's a new antiviral coming out. It's called baloxavir. And maybe some of you read about it. It was really, the media made a big mistake, and they said it's the new drug that will kill the influenza virus in one day. Not the case. What baloxavir does is the same thing as the neuraminidase inhibitors, but a neuraminidase is one protein. The baloxavir stops the duplication of a different protein. Difference is it's a one-time thing, one pill, whereas with Tamiflu, it's twice a day for 5 days. So it's in the process of being okayed by FDA, possibly by sometime this season, but I don't think it's going to be very available. So I'm looking forward to it more in the 2019-2020 season. Vaccine strategies to reduce influenza infections. They're safe and effective, and we're going to talk about vaccine efficacy shortly. And the vaccine efficacy is different than a match. We're going to get into, and I think Pete will talk about this a little bit later, but a match means it's genetically the same thing, but the vaccine efficacy is something totally different. The two options we have are inactivated vaccine, which is a trivalent. It covers both influenza AH1 and AH3, but it only covers one out of the two Bs. And the quadrivalent vaccine covers both influenza Bs, both the Victoria lineage and the Yamagata lineage. And as I mentioned earlier, the last 2 years, the trivalent vaccine did not cover the correct influenza B that was circulating. And a lot of people over 65 who had that flu zone or the adjuvant type of thing, which actually increases and gives you better immunity to the top three, H1, H3, H1, and one of the influenza B viruses, it completely missed the B viruses, leading to an extended season, leading to more and more mortality. This year coming back is also the live attenuated virus. That's the MIS for people up to 49 years old. It was dismissed because it's thought to be ineffectivity to the H1 virus over the past few years. There's still some controversy out there. You know, the people in Canada, the doctors and clinicians in Canada swear by it. There's still some reluctance with doctors around here. And because it was only okayed in February, a lot of places were not able to order it. So it's not the easiest thing to find. It is out there if you look hard enough. If you have children who will not get a shot, it is a good alternative to use. Again, it's a very safe, but it is a live virus. So you always have to be a little bit careful of those particular things. Now, vaccine effectiveness. Hopefully I can explain this. This is the overall vaccine effectiveness for the last 5 years. And you can see the thought that we were going to have like a 10% vaccine efficacy like they did in Australia did not turn out. It was about the same as what we had the previous year, 2016, 2017 year. Both about 40% overall. You always, in the H1 years, you always seem to have better vaccine efficacy, up to 48% in the 2015-16 season, and well over 52% in 2013-14. Part of this has to do with the H3 virus and how it's actually made in eggs and how they actually inoculate the eggs with the virus, but what they're putting into the egg is not what's coming out. It's called an egg adaptation. Something in that egg is happening where it really changes the structure, changes the whole efficacy of the H3 vaccine. And that's something, because we have such an archaic system using eggs, we really would love the manufacturers to start looking perhaps at cell-based cultures. I think that is in the long run. But influenza vaccine is not a moneymaker too. We have to realize that. There's only a short amount of time that you can give it. It's a new product every year. I think there's only 2 or 3 manufacturers who make it, where years ago you had 5 or 6, maybe even 7. So breaking this down real quickly again, this is the influenza vaccine by the actual virus. And again, 40% for all overall. It was only 24% effective against the H3 virus, which is by far the predominant virus in the 2017-2018 season. The AH1N1, 65%, that's really good. You know, I mean, you're never going to get 100%, but if you get over 60%, that's really good. And the B. Yamagata's, again, were about 50%. There weren't enough of the B. Victoria strains around to really do a vaccine efficacy study on that. But I want to break it down one more time with the H3, and I want to show you something. Again, 24% for all ages. 6 months to 8 years is 37%. Thank goodness for that age group, because otherwise this would probably been significantly lower. Why is it higher in the 6 month to the 8-year-old group? More than likely, a lot of these kids are getting their vaccine for the first time, which means they get their second shot, their second vaccination 1 month later. Probably gave them some better protection. 9 to 17-year-olds, 10%. And look at the long line. That's the confidence interval. I mean, it really are not sure about some of these numbers. It's not as black and white as what we'd like it to be, but 10% efficacy for that age group, and the 18 to 49 years old, a little bit better than the 50, 64-year-olds, and again, way down for the over 65-year-olds. This is vaccine efficacy. Again, the match was not that bad. The vaccine working was not that good. We're hoping that by the 2 changes that we made this year in both the H3 virus and one of the influenza Bs will improve this significantly. We are going to be very optimistic, like we are every year. We are encouraging people to not shy away from the vaccine, but to really keep going and get vaccinated, not only for yourself, but to protect those people who are around you. What was expected, again, was largely what we got. It was not a bad match last year. But again, some of the vaccination rates, and I have some numbers from Wisconsin that I thought you might be interested in. If I could find mine quickly. I thought I had this right page on here, and I apologize for that. But significantly, in Wisconsin, 35% of the people got vaccinated. That's not good. Our 2020 health goal is 70%, and I don't think we're going to get it. You may think otherwise, and I hope you're right. But again, 35%, and that was even better than we had the year before. That was like 33%. But the highest numbers is about 50% in children 0 to 4 years old, only 25 to 30% in those 5 to 49, and it really was pretty good over 65. It was about 60%. But once you get into the 5-year-olds to the 49-year-olds, the vaccine rates are horrible. I don't know why this is, Maybe we need to do a better job of selling the vaccine and making sure people know what it's all about, that its main purpose is not to prevent, but it's to prevent complications and to protect those people around you. Maybe the message needs to be changed. Seasonal influenza vaccine, why isn't everybody getting vaccinated? It's a trivial disease. Why bother? I don't get it. You hear this all the time, and unfortunately I hear it from my own colleagues. It's not safe during pregnancy. Well, it's proven time and time again it is. You can get it in any of the 3 trimesters, and it gives the best protection for that child who's about to be born during that first 6 months when they cannot be vaccinated. Not another vaccine for my children. Well, that's why the intranasal vaccine is now back. It's for those children specifically who do not want to get another poke in the arm. There's a lot of them, we know that. So it is an option now, again, to have that intranasal to come back. I got the flu shot and I still got the flu. Well, if you've been exposed to it shortly before you got the flu shot, you can get the flu, but it's not caused by the shot. It's a dead virus. The shot is a dead virus. You cannot get the flu from an influenza shot. There's thimerosal in it. It's like a small mercury compound, but there are many vaccines that are thimerosal free. So it's a preservative, and it's usually in the multi-dose syringes. The single syringes do not have thimerosal for the very most part. And costs too much. It's really not that much. I've heard people saying, yeah, I had to pay $200 for it. Well, somebody's making, a big profit on that for no reason. That's just ridiculous. They shouldn't be costing more than $35, $40 tops, maybe at like a Walgreens or a CVS. And it's not as effective as the government says. Well, we never said it's been 100%. We try to explain what vaccine efficacy is. Some protection is always better than no protection. Think of yourself going outside in 10 below degrees weather. If you have a light jacket or something to go out and get your mail or do whatever you have to do outside, go to the car, it gives you a little bit of warmth. You won't freeze. That's the same way with the vaccine. You need some protection. It's a very rough disease. It's a very severe disease. We obviously had thousands of people die last year. I think the estimate was like 80,000 last year. It's something that we have to take much more serious than what we are in the past. And again, that's partially my job at the state, is to work with our immunization program to do that. Could there be problems with the vaccines? It may not, as I said, it may not be perfect, but it does give a substantial people the best we have, and that's a CDC source. So again, I will encourage you, if you haven't got your vaccine, to get it as soon as possible. Do not worry about waning. It should last, if you get it now, it should definitely last you through the season. There's been a lot of talk that you lose the vaccine efficacy of 10% or more every month. That's still not totally proven. There's a lot of studies that are out there. There's some studies that says it will definitely get you through a season, but we're dealing with such a severe virus. I really hope that it's a much better year than what we've had in the past, especially after last year. No predictions this year. I don't want to put my foot in my mouth again. I won't do that. But I'm confident that it's going to be a much better season. And with that, Pete, I'll let you finish up.
Thanks, Tom. In the time remaining, as I said at the outset, I want to kind of reassure you, this is a bad bug. We don't have the optimal way to prevent it, but I reinforce what Tom, the public health party line is. It is the best we have, and it's way more effective than a lot of people give it credit for. You've got to get that vaccine. All ages need to get it. Despite the limitations, despite severity of the disease, over the last 20 years, largely because of the concerns with pandemic flu, we have developed an incredible influenza surveillance system that is now global. I'm going to quickly tell you what goes on globally and then get down to the U.S., because within the world, the United States really has the most robust model for flu surveillance, and we're constantly exporting that to other countries and helping them get to that same level. And then I'll second Tom. Wisconsin is second to no other state in the country for state-level surveillance that actually advises our national surveillance. I'd say in general, there is no other infectious disease, period, in the world, in the United States, that is surveyed and followed and monitored as closely as influenza. There's not even really a close second here. So it's really quite an impressive system. First, there's global surveillance happening in humans. And when you look at the map, in the United States, CDC is the lead agency. And in fact, they're a lead public health agency for the world, being one of the primary response agencies in collaboration with the World Health Organization. And each year, more and more countries are developing their own influenza surveillance centers that are going into this global network. And they're being tasked with setting up surveillance models within their country that look within their country and then advise the greater global surveillance. And the number of countries able to do that and the degree that they're able to do that is growing each and every year, largely through the efforts of the US and some of the other wealthier countries that are helping the rest of the world catch up with their surveillance. Moving on, there's also very extensive animal surveillance, and the purpose of this surveillance is to be detecting those novel subtypes, those viruses that have a potential to get into the human host and lead to a pandemic. They're looking in bird populations, migratory as well as domestic bird. There's also swine surveillance in different countries around the world. And these are just a list of the different novel subtypes that each and every year are being detected. They then have very extensive surveillance looking particularly for outbreaks in domestic poultry or in migratory waterfowl, which may indicate there's been a fundamental change in that virus that could then portend that maybe a similar change could happen in humans. And then what the CDC, World Health Organization, does is they look at all these novel flu detections and the monitoring that's being done, and they apply a number of criteria to each new novel subtype that is seen and try to estimate what is the potential this could emerge in the human population, and if it does, what is the likely public health impact? They have a very extensive algorithm that they apply. And basically, they rank these, and right now I made passing reference to two novel subtypes that have been on our radar for a while, H5N1, H7N9, and those easily sit at the top of the heap of those novel subtypes that bear special attention because of their potential to trigger the next influenza pandemic. And again, the number of mutations necessary for that sustained human-to-human spread, partly through study that's been done on this campus, have been found to be relatively few. So it is very important that this type of surveillance continue. You then get to the US surveillance system, and it's broken up into basically three categories. There's virologic surveillance. I'll come to that in a second. It's what my lab participates in. Morbidity surveillance, where we're looking at influenza-like illness, and it's the magnitude, the extent it's occurring, and it's spread throughout the country. We're looking at hospitalizations, which is obviously on the more severe end of the spectrum as far as influenza disease. And then mortality surveillance. National Center for Health Statistics keeps statistics for the whole country on deaths due to pneumonia and influenza, and that helped populate that curve, those curves that Tom showed you about mortality each influenza season. Childhood influenza is now a reportable condition, I believe, nationwide. All states are doing it. And I'm telling you, the first thing you hear, 80,000 people died of flu, but only 180 children. These were unvaccinated children, and each one of those, and we get involved with these cases in Wisconsin, they are absolute tragedies. In most cases, in many cases, those are otherwise healthy kids who just, bad luck, gets a severe unremitting illness and they die, often unexpectedly. And these it doesn't matter whether there's only one of them, they are way more tragic than a lot of the other illnesses that we see, and it's really heartrending when you see this. Now, all of these data then are accumulated at the national level and then are sent back out to the states, to Tom and his counterparts throughout the country. And also you can access these at the CDC by going to their website, www.cdc.gov/flu. And go to FluView because it gives a very good and understandable synopsis of what's happening with influenza on a week-to-week basis in the United States. This is just a compilation of the data. Tom showed you this. These are the types of data then that they show you as the season progresses. Virologic surveillance. Public health laboratories are tasked with working with CDC to pay special attention to those viruses circulating in the United States. We work with our clinical laboratories throughout the state who do a lot of their own influenza testing to gather their data of how many tests are they running and are they seeing influenza A or B. Those isolates then come to my laboratory and we look for the subtype. We look for whether and confirm whether it's influenza A or B, look at the subtype for influenza A, and determine which lineage of influenza B. Through these data, we know that each of the last 2 years, the trivalent vaccine missed on that flu B that was circulating. We knew that very early on because we were doing the characterization of the viruses. We're also always looking for novel and reassortant viruses throughout the year. We do our surveillance year-round now because we have these cases that come up that are swine origin or avian origin. The work we do then is shared with CDC along with the specimens we've worked on. We give them to them by the middle of the flu season, right around January, and then they make a selection of all the different isolates and viruses we've worked on throughout the country to determine which are the ones most likely to be circulating next year, and they begin the development of their vaccine, which is a 6 to 7 month process. So we're heavily involved in determining what viruses are going to show up in that vaccine. And we also detect and monitor antiviral resistance. This is just a shout out. We've got 50 clinical labs. There are 132 total laboratories in the state, hospital-based laboratories. 50 of them are now active doing state-of-the-art molecular influenza diagnosis. And we get data and specimens from each and every one of them. And we really are a model for other states. We're working hard with other states so they can kind of develop similar networks within their states. And all these data and all these isolates go to the CDC for further characterization. So with that, that's a synopsis of surveillance. I want to just leave you then, kind of wrap up. One final slide, parting message. First of all, hopefully, even before this talk, you recognize the clinical importance of influenza and the public health importance. Not only pandemic, it would have been really easy to talk about pandemic influenza and wow you with really what bad things it does. We thought it'd be more appropriate to let you know what confronts you each and every year. This is something you need to deal with for sure. Pandemics may happen next year, may not happen for 30 years. But be assured you're going to have another epidemic next year and we're going to have to deal with that. And respect it. And a lot of people do not. It's a serious illness. I'm in the same age group as many of you. We sit at the top in terms of being a risk group here. And that's got my attention, and it should have all of our attention. Protect yourselves. Vaccine isn't perfect, but it does protect some people absolutely, and it protects a whole lot of people to the extent that it lessens the hospitalization rate and reduces the mortality across the age spectrum. And that ain't bad. And we need to recognize that. And when you feel like you might have influenza, and Tom gets a lot of press, he's in front of us on a week-to-week basis. You have these reports. If you think you have flu, the number one recommendation is call your healthcare provider. tell them they can order up an antiviral, which if you get in that first 1 or 2 day window, absolutely will reduce the severity and also incidentally will keep you out of the hospital and keep you alive. So it's a good thing. You need to proactively reach out to your healthcare then. And protect yourselves by being aware of what's going around in the community, in the state, and nationally. And finally, protect others. Tom shouted out one thing here. Flu isn't, and any vaccine isn't just about the recipient of the vaccine. There's herd immunity. We owe it to each other to get vaccinated to help protect those who need further protection, those of us who are in risk groups. Cover coughs, wash your hands, all the hygiene things we hear all the time. And the parents in the audience, you need to keep your sick kids out of daycare and out of the school. And those of us who drag ourselves into work faithfully, we're only sharing the joy that our kids brought home to us. And we have to be a lot better of realizing when we're fairly sick, we're serving nobody, plus we're not really that much worth at work, by going there and spreading the disease amongst them. And it's very important we all take that to heart. So with that final message, thank you for your attention, and in any time remaining, be glad to answer any questions we can.